and right from the at outset, I'm very thankful to the Criticon organizer to have given me this opportunity to talk really a difficult subject, to call something on one hand a useful and then on other hand to call it a harmful modality. I think it's too much to think about a modality which has been in existence for more than 2.5 to 3 decades with us. Before I proceed on my discussion, I would like to know from the House, how many of us had a very first-hand experience with any modality of CRT? Would you raise your hands? Raise it further so I can see it far. Good. So I can see about 30% people have at least experience with something or one or other modality of CRT. Now I would like to have another very important question. How many of you who have first-hand experience with this modality feel this is a harmful modality? Any hands to say this is a harmful modality? None. Nobody wants to say this is harmful. So you all agree to the fact this is probably a modality which had been to the rescue of, not to the patient, but to the rescue of the critical care experts who are working in the ICUs, rescuing the patients with renal failure or renal insufficiency. But very important factor which has been raised in this particular talk is this: is it a modality which is useful in sepsis or not? Is there any problem with the mics? Am I audible now? Is it okay? An important fact come close to the fact that this sepsis-related modality, is it useful in this context or not? Now, just an overview about all the modalities of CRRT. If you see, these first 5 modalities are pretty well known to nephrologists and those who are practicing critical care in ICU. From the SERDA and Ronco's Handbook of Critical Care, where they have defined another 5 modalities and been included into this gamut of the CRRT, or you can call it an umbrella of the CRRT, which is continuous plasma filtration and exchange, continuous hemoabsorptions, and this is coupled plasma filtration and adsorption, and high volume hemofiltration. This is a particular modality which has really been looked in, particularly in pertaining to the sepsis in the last 1 decade. Now, as we move, what we are looking when we are either decrying a modality or we're looking for the usefulness of a modality, what we are looking particularly in context with CRRT, are we looking as a support system to the renal failure or a failing kidneys, or we are looking only to the managed sepsis? Probably this would be answered in the next talk when the speaker is going to talk about the oliguria management and to start what time they should start with the renal management planning in these patients. Or are we looking for a specific subset of a condition called sepsis-associated AKI, which is probably a distinct than the routine AKI or ICU AKIs? Or we are looking something beyond this. So defining these goals, if you look at this SOAP study, look at this SOAP study, 24 EU countries, 198 ICU, more than 3,000 patients. About 1/3 of these patients had AKI. And if you see the mortality rates among the AKI group is 36% as compared to non-AKI group, which is about 16%. And out of this AKI group patients, there were about 1/4 of these patients required renal replacement therapy. And see the outcome of these patients who required renal replacement therapy, whether they were ICU mortality, hospital mortality, ICU stay, hospital stay, they were distinctly poorer as compared to the rest of the group. Not only the rest of the group, but with the AKI group, which did not need the modality intervention in these points. Now, let's look at this particular group, which has mortality rates much higher. Now, it's requiring some kind of a support system, and we're looking at that support system, whether it's going to be useful or harmful in these particular patients. None of your ethical committees are going to allow you to carry out a trial or a study which would look in whether the utility of modality or no modality or a placebo modality. This kind of a trial probably can never be conducted on these patients. Now, what we can look into these patients, can these patients be managed with something less than CRRT, that is intermittent hemodialysis? There are a couple of data available to that. We'll try to compare CRRT with intermittent hemodialysis in this setting. Now, other observation which has come up in the same study is the early start of renal replacement therapy has a better outcome, which in itself, in its own capacity, gives us insight into the fact that if we do not deal with these patients or appropriately treat them in time, we are going to lose these patients. Probably the mortality are going to be higher, which itself justifies the fact that CRRT is some kind of renal replacement therapy, whether it's CRRT or intermittent hemodialysis, is needed in a subset of patients who develop AKI, whether in the setting of sepsis or otherwise in ICU. Now, this is a very important study, which 360 patients, about 4 years of compilation in 21 French ICUs. This is by Christopher data. What they look at is survival in these patients for 60 days. When they compare the intermittent hemodialysis versus venous hemofiltration, there is no survival difference, 32%, 33% in both the groups. So which modality is superior when we are looking for critically sick sepsis patients? Now, this is the data which is compiled, though it's about an older data, about a decade-old data, about 10 studies, 12 studies, which have tried to look in for the superiority between CRRT or intermittent hemodialysis and ICU setup patients. Majority of the studies, if you see, they could not really correlate any kind of outcome specific in favor of any of the modalities, except these three, the SMILEY modalities. If you look at these SMILEY modalities, these three studies have shown some kind of benefit in terms of CRRT, which is in favor of CRRT as compared to intermittent hemodialysis. And if you focus on this last study, the meta study, which I'll show more in detail, again a large study from San Diego, ICU mortality with CRRT was 60% in this study as compared to 41% in intermittent hemodialysis, a statistically significant and clinically important difference. Now, here one can say probably, at least there are studies which, or the similar studies to the Ravi Mehta study, which has shown that CRRT patients might be doing worse as compared to intermittent hemodialysis patients. But as a clinician practicing in ICU or CCUs or in critical care situations, we know one fact. When we assign the modalities, we look in for the patient's basic standards or basic severity of the patients, and the assignment always goes accordingly. So once they did a logistic regression analysis adjusting for any confounding factor, the statistical difference in the study was mitigated. So what does that mean? That CRRT probably, at least, is comparable to intermittent hemodialysis, or maybe in very, very subtle settings, it might be as superior as compared to intermittent hemodialysis. Now, but another observation which has come up and which is more important for critical care ICU people is the compilation of fluid. And if you see intermittent hemodialysis, this is not one study. In fact, the SOAP study also has shown very clearly there is a compilation of fluid in the body which affects the ALI, acute lung injury, and over a period of time, these patients may have a difficulty in extubation from ventilation or weaning off from ventilation and other processes, but this outcome has not been, if you look at the previous the data which I have shown, whether it's a Ravi Mehta study or the Christopher Coffey study, this data actually has not been really giving any kind of favorable outcome in these patients. Now, this is another area of CRRT which has been in debate for the last 2 years. 2000, when this study came from the Ronco and Bilimo's group, I thought probably this issue that how much CRRT dose should be given to the patient, whether it is 16 ml or it's 35 ml per kg per hour, this issue seemed to be settled at this particular point of time. But unfortunately, or rather I would say it's still debatable, it's quite in fluid, which we have to proceed. But at least two large studies, one is this ATN study, another is a renal study, which have looked in the dosage variance among these two patients and the outcome in terms of dosage in these patients. What they found is the cumulative crude mortality was not different whether you assign a higher dose modality to these patients or the lower dose modality to these patients. So CRRT, whether you assign about 16 ml 1 liter clearance, 25 ml clearance or 36 ml clearance, it does not give much variance in terms of patient outcomes. That had been at least shown by these two large studies. Now, but there was some specific subset. If you see the data which has come from the Ronco-Bilimo study, there was a very subset of a patient which was septic or septic AKI patients. When they looked into this particular subset of patients, what they found that 45 ml dose, higher dose, was probably giving a better results or better outcome in these patients. Now, this led to build-up of a new hypothesis in last decade. Now, this hypothesis was actually looking into the fact that are we dealing with AKI which happens in ICU setting only in a septic patient which does not have, which is not an AKI which happens in non-septic ICU patients. So is it a different entity or no? Now, this has been corroborated. This has not worked. Can I have another one? If you look at this Bagshaw's data, they've tried to look in for I'm sorry, you're going to change it now. Okay, I'll use the pointer from here. Now, if you see this Bagshaw study, and they've tried to look in for ICU stay among these patients, whether the median ICU stay or a hospital stay, in comparison to different cohorts of acute renal AKI, whether it's a risk or injury or failure. If you see the patients who are septic, And those the patients who are not septic, as compared, they have a different outcome in these patients. Similarly, when they looked at for crude ICU and hospital mortality, stratified by their subgroups, whether it's purely sepsis or it is non-septic AKI or septic AKI, there's a very discrete difference in the two groups. And if you see the hospital mortality among these stratified with AKI or the stratified with the rifle category among these patients, again you see the patients who got a failure or the AKI with the failure group, as whether their hospital stay or an ICU stay had been much longer as compared to the patients who were not septic among these patients. And if you see the summary for their acute physiology and laboratory parameters among these patients, the important ones, if you see, like mean arterial pressures, if you look at their PaO, FiO2 ratio, if you look at their pH, and if you look at their Apache 2 scoring, all they were statistically significantly different from patients who had AKI but did not have sepsis. So this had led to a belief which had only not been substantiated by this study, it had been substantiated by all the studies which had been looking into this prior to that, that septic AKI may represent a unique pathophysiological condition and as such may deserve a consideration for separate stratification for the randomization or a priority identification for subgroup analysis when applying for therapeutic strategies and designing a future trial. So that means what we've been looking in for the last 1 decade, a specific subset. In which context we are looking in, particularly in terms of performance of CRRT and choosing the selection of CRRT, the modality, because at the same time, what we are finding is these, the various cytokines which are mediators for sepsis or septic shock, they had a different kind of profile among the patients who had septic AKI, like IL-6 levels, soluble TNF receptor 1, platelet activating inhibiting factors, and there are a couple of studies. I'm just showing the studies which has shown that all the patients who developed septic AKI had relatively higher levels of these mediator substances which has been contributing towards the sepsis. Now, if you look at this particular Picard study, IL-6 levels, IL-8 levels, and CRP levels and TNF-alpha levels in patients who had AKI as compared to ESRD. ESRD is somehow is not visible, but then this particular group was pretty smaller as compared to AKI group, has shown very distinctly that this particular group has high mortality, and the higher quartiles for these values of these mediator substances had highest odds ratio for the death among these patients. And similarly, this is another study which has which is published in KI, which has again looked in for the lesser survival in patients who had high value for these mediator substances. And this is a study which has this is the last about 10 years, cumulative studies, which have tried to look in that CRRT clears all these mediator substances. Now, what we have been piling up is that probably a different subset of AKI as a sepsis. These are mediated through mediator substances, and these mediators probably can be cleared by CRRT hemofiltration modality. Now, harping on this kind of information which has been generated in the last 1 decade, a couple of studies attempted a high volume hemofiltration. Now, let's look at the results of these studies. This particular study, the patients were pretty sick. If you see the Apache score among these patients was more than 25 always. And they assigned an ultrafiltration which is far higher as compared to the standard one, which is more than 60 to 100 ml per kg per minute. And if you see their overall survival rates, which are much more than expected survival rate among this particular set of patients, 45%, 54%, 55%. But does that mean that this is the end of the story, or we have achieved some kind of a modality which will give us the right answers? Yes, there was a missing link in the entire of this. The missing link was whenever there was an estimation for the plasma level of these mediator substances was done, it was found that these mediator substances had the same level as to start with CRRT at the end of the CRRT. To explain them, all the proponents who has been proposing all the CRRT modalities have given different these hypotheses to explain this, like peak concentration, where there is energy between the between both the states of cytokine levels, whether we are talking about SARS or CARS, they achieve a new hemostasis where the new immunomodulation and the immune paralysis doesn't happen in these patients. Similarly, these two particular hypotheses deals with the tissue clearance levels were increased with the modality of CRRT. So, letting to the net result that probably there are other pathways which were probably removing the tissue levels of these immune mediators or the cytokine levels. So that's how probably these modalities were improving the outcome. But if you look at this particular meta-analysis which was published just few months ago. The net outcome among this particular, which included 12 studies, including the 5 studies which I just quoted, the high-dose renal replacement therapy in AKI does not improve patient survival or recovery of renal function overall or in important patient subgroup, including those with sepsis. So finally, again, after completing the complete circle, we have an outcome status which still stands no way. Whether this modality is going to improve the septic patient outcome, all the hypotheses which has been generated over the last 1 decade still needs to be further looked in further. And this is my probably a last study. This is a commentary by Powell and Balimo, which try to look in AT and renal trial. What they have said is that consensus currently is, emerging consensus is that CRRT is most appropriate treatment for AKI and vasopressor-dependent patients in ICU settings. This is what we all clinically practice. When we find a patient who is hemodynamically stable, we probably assign them intermittent hemodialysis or a SLEG. But the moment we find a patient who is hemodynamically unstable or whose requirement of pressure drugs is higher, that's the time we choose and for. So it is nothing which we are not practicing, which has just come up in the last 1 decade. This is a trial which we are still waiting if there is anything comes in favor of septic, management of septic AKI in favor of CRRT. So I would conclude, probably still we are not in a state that we can make a very clear statement whether this is a modality with us for the last 2.5 decades is of any use, or whether it still needs to be looked at further, or what are the likely outcomes. This is not our status. If you look at this, this has been a questionnaire regarding which Zakaria Risi asked by 540 people in one of the critical care nephrology meetings, and the answers were similar, that there was a sufficient, about half the people feel that this is a modality which probably is not going to take us any which way, and half the people feel that probably this is a modality which is going to, despite having scientific evidence at the level of some smaller studies, we lack sufficient scientific evidence or level 1 evidence in favor of this particular modality. So I would leave my talk at this level. Thank you very much.